Good evening, everyone. I'm Andrew Penn. I'm one of the co-founders of Open Nurses, and it is a pleasure for me tonight to get to interview one of my friends and colleagues, Hannah Whitmore. Dr. Hannah Whitmore is a certified hospice and palliative care nurse and a clinician scientist dedicated to supporting individuals and their loved ones in navigating serious illness and end-of-life transitions. The spark that began her journey was lit in 2008 at the eco-village of Findhorn, Scotland. We're going to have to hear about that story. And continued through her work in hospice care in Boulder, Colorado, Santa Fe, New Mexico. She holds a PhD in nursing from UCSF, which is focused on symptom science and psychedelic-assisted therapy to address existential distress through promoting death acceptance. She has 17 years of meditation practice under Tibetan Buddhist teachers and studies in contemplative psychology at Naropa University. And she integrates mindfulness-based approaches into her care. She's worked with diverse communities, including combat veterans, LGBTQ plus individuals, and underserved populations, providing culturally sensitive care. Currently, she's a postdoctoral fellow at the UCSF International Center for HIV/AIDS Research and Clinical Training in Nursing. Her research focuses on the implementation of psychedelic therapies for the seriously ill and HIV-positive community. As an end-of-life consultant, she empowers individuals and families to navigate complex healthcare systems with clarity and confidence, advocating for their rights and ensuring care that honors their values. So without any further ado, let me welcome Hannah, Dr. Whitmore, onto our screen here. Hey, Hannah, nice to see you.
Hey, Andrew, great to be here with everyone.
Yeah, thanks for being here. And for the folks who'll be watching this later on in the post recording, which is where we get most of our views, it's available there for anybody who wants to send it on out. So, we always start these kind of similarly. It's there's so many different ways that people get into nursing. I'm always interested in how people got to where they are now. So you tell us a little bit about your journey?
Yeah, so in a nutshell, it started way back in 2008. I was in this eco-village called Findhorn in Scotland. And at the time back in the States, before I went out to Scotland, I was working at this Waldorf-inspired preschool daycare center with the littlest ones. And then for whatever reason, in this eco-village, which is known to be like a spiritual, transformational, educational place, I had this flash of insight that I needed to learn how to care for people at the very end of life. So the opposite end of the spectrum. I have no idea where it came from. It just came through very strongly. And then when I got back to the States, back to Boulder, Colorado, I got my first job as a caregiver in an assisted living facility, a very small one, taking care of end-of-life folks. So I got my first exposure in that way.
Okay.
At the same time, I was going to Naropa University. And back before the whole talk about psychedelics possibly becoming medically legalized, there was a lot of grassroots community ceremonies happening,
In Colorado? You're kidding.
In Colorado, I know.
I can't imagine that. Yeah.
Somehow, I learned a lot in that space, and it was really profound for me. So the third stream into all of this was my introduction to my Tibetan Buddhist teachers. And in Tibetan Buddhism, they are adamant about recognizing and acknowledging the reality of impermanence and death. It's just really woven into the meditation teachings. So those three things really came together and kind of formed a confluence back then. But I wasn't able to really hold them all together simultaneously until much, much later. Went to nursing school in New Mexico, moved out here to California, started at UCSF, and they were gracious enough to accept me into the doctorate program, and they accepted my research ideas for psychedelics for end-of-life care.
Yeah. I remember when you were first starting to think about that, when you were just starting your doctorate a few years ago, because you just finished last year, this in 2025, right?
Yeah, in October 2025,
Okay.
and launched into a postdoc.
Yeah. So so many questions in there. So, this, I mean, it totally makes sense to me, this idea that, like, you'd be interested in young children, and then that leads you to an interest in end of life care. I mean, some of the best psychedelic clinicians I know, were like labor and delivery nurses, doing
Mhm.
things like that. So, the sort of transition on one end from the other makes a lot of sense. I'm interested in how your sort of background in Tibetan Buddhism kind of informs that work that you do with end of life, because you mentioned that impermanence is kind of a running theme in that spiritual tradition. So for people that aren't familiar with Tibetan Buddhism, could you kind of give us a little framework there and how that informs the kind of palliative care work that you do?
Yeah, so there's a lot there, but basically, in the Tibetan Buddhist framework or philosophy, it's part of the core teachings of contemplating our mortality and contemplating just the very reality of impermanence.
Okay.
It's not even necessarily religious. Like, I think everyone can agree that impermanence is the constant throughout everything. And whether we like it or not, we are all mortal and
Mhm.
progressing on towards our decline and our eventual death, all living beings. And so they use that contemplation of impermanence and death as a very sharp, yet compassionate wake up call into awareness.
Huh.
And my understanding is it's a segue into compassion and um, further expansion of awareness as we plod along here.
Yeah.
And so I officially don't talk about my roots or my approach from Tibetan Buddhism when I'm working actively in hospice and palliative care, mostly because I want to respect the patient and family's own faith tradition and backgrounds. But it's something that once you're involved in meditation or any spiritual tradition, you just kind of embody it naturally, right?
Yeah.
So every situation I walk into, especially the most difficult ones, because there's some gnarly ones, it's just something that I carry with.
Mhm.
And it's helped tremendously in my resilience in the field. Hospice and palliative care is a high burnout nursing field for
Yeah.
obvious reasons.
Yeah.
It's just really helped me to understand why I'm in there and how acutely important and sacred our own life situation is now.
Yeah. Yeah. I like that idea. That's sort of like that jarring. It jars you out of your complacency, right?
Yep, it really puts things in a perspective.
Yeah. And do you think that there's sort of a parallel between that and what sometimes people experience with psychedelics, whether it's that same kind of jarring, or if there's something about impermanence that is kind of parallel to that?
I think so. And, the caveat's always going to be that every individual's experience is going to be unique to them and their mind, right? But I think definitely so, in that, in a way, with psychedelics, and studies have shown with advanced practice meditators, that
Uh-huh.
there is this a similar neural correlates
Yeah.
of ego dissolution, right? So that's super fascinating.
Right.
Um, and so I think, my hypothesis, and all of this requires much more study, of course.
Yeah.
My hypothesis is when used with intention in the right setting and right support, that psychedelics may help people come to that acceptance and awareness of our impermanence and eventual death. And it I see it as like a signal boost for that understanding
Right.
that meditation eventually can get us to that same place too.
Yeah, because I mean, I know there are kind of well-known meditation teachers. I mean, Jack Kornfield comes to mind. Who sort of had their first experiences with psychedelics, and then sought that out through different means, that didn't involve uh, a substance, and found meditation. And so, in that same sort of way of like different ways to the same endpoint, it sort of sounds like there's some parallels there. Because one of the things that you hear from people, and I'm curious how this kind of tracks with your experience in like the study you're working on and such, and I want to get more into that in a moment. But like, people talk about like psilocybin sometimes being like a rehearsal for death, because of sort of ego. Ego death is such a sort of feels like such an overused term, but that just that sense of like, oh, I'm part of something bigger than just my own little internal experience, right?
Mm-hmm.
Do you feel like that there's a intersection between like sort of the way that like your spiritual tradition and your experience with working with end of life patients kind of intersects around kind of like getting out of the way? I'm not articulating that. I'm kind of rambling. I'm sorry.
No, I know where you're going with it. Yeah, absolutely. I think, just from my small understanding, my small experience with all of it, is the psychedelic experience doesn't necessarily add on to who or what we are, but rather it seems to clear away all the cobwebs and the debris and our own self-centeredness and our own small contracted suffering
Huh,
into a much, much, much larger space.
okay.
And in that way, I think it might help us really look towards and prepare for our own death, because we're no longer in this fishbowl of swimming around with just ourselves and our own tormented minds, right? It's the fishbowl is blasted open to meet the larger space outside of it. And in
Yeah.
a way, as far as any of us know, that's kind of what death is. We're no longer confined to this body, to this contracted state of mind, to this contracted identity in this lifetime. And psychedelics, for a lot of people who've reported back their experiences later, very similar experience, getting out of themselves, right? Out of their own suffering. So,
Yeah.
yeah, it's just a huge mystery, but I'm here for it.
I love it. And where do you see your nursing background coming into this?
Well, because we are still in these bodies that do get sick and are aging constantly and are pretty complex, especially these days, I think the hospice and palliative nursing came in because I saw clearly that we we really do need very solid clinical skills to help alleviate the physical suffering at end of life as well, right? As much as we'd like to meditate and pray away the pain or the nausea, probably won't happen like that.
Right.
So the clinical skills of being a hospice and palliative nurse has been just so huge and impactful, And so really I kind of see it all on the same platter, right?
Yeah.
Yeah.
Yeah. And you're doing some of this work right now on a study at UCSF, right? Can you tell us a little bit about that?
Yeah, so that study is I'm probably going to butcher the name, but it's a pragmatic trial for psilocybin therapy in palliative care.
Okay.
And so we are currently enrolling people who have 2 years or less to live, who are very, very demoralized and having a hard time coping. So we understand demoralization to be extreme hopelessness, extreme loss of meaning.
Okay.
It's separate from depression, but often can be seen alongside depression.
Okay. So it's different than depression.
It is distinct from depression,
Okay.
but they sometimes get confused. You can have both at the same time, but demoralization is its own experience, sometimes within depression, right?
Okay.
So we are looking at just the feasibility, the safety, and if psilocybin may help those folks with severe demoralization towards the end of life.
Okay.
we're using a control of low to moderate ketamine. It's a triple-blind randomized controlled trial. So if the participant receives the placebo ketamine, if they choose to be unblinded later after receiving it, they can cross over and then receive open label the full therapeutic psilocybin dose. And
probably,
we're
okay. You
and
probably
we're
don't use the term crossing over with your subjects, though.
what's that?
You probably don't use the term crossing over with your subjects. That might be a.
Yeah, we might use different wording.
So I come into the study. I have a life-threatening illness. I'm feeling really demoralized, which is like depression, but it's more about like it's more focused on the sort of hopelessness and like what's the point, and
Yeah.
my life doesn't have meaning. Maybe I've got a lot of regrets.
Yeah.
And I want to examine that. And so I'm randomized to either get psilocybin or a low dose of ketamine.
Low to moderate.
Low to moderate dose. Okay. So that sounds like that is kind of an effort, because there's always been this problem with psychedelic studies, right? Where people tend to know if they got a psychedelic or a placebo. So this kind of muddies the water a little bit for blinding, right?
That's the intention.
Okay.
The intention. Yep.
And then if it turns out I was randomized to get ketamine, then I come back in and I can get psilocybin the second go round.
Yeah, if it's still medically safe for that participant.
Right, because you got people that their condition is changing, right? They might have a very, they might have like something that makes psilocybin not medically appropriate, right?
Yeah, exactly. And all of this is done with the meaning and purpose therapy to be adapted for psilocybin.
Okay.
So the integration visits, the dosing visit where they receive the study drug, and then the preparatory visits, the dosing visit, and then the integration visits. It's all encompassed and delivered with meaning and purpose therapy to be adapted to psilocybin.
Okay.
So the meaning and purpose therapy is really relevant and really appropriate for end-of-life folks doing this work.
So everyone gets that regardless of which condition they're randomized into.
Yep, exactly.
Okay. And can you tell us a little bit about what meaning and purpose therapy is for those who aren't familiar?
Yeah, so the root of it really comes from logotherapy, which goes way back to World War II time. And it's basically deriving meaning and our values to fall back on in times of intense hardship or stress. And it's going to look really different for each individual, but it's basically looking at what exactly are my personalized values? What is the most important thing to me as I go throughout this intense hardship, or in this case, a terminal illness?
Okay.
Who's important to me? How do I spend the rest of my time? What are my care values? And so in that way, it really creates this existential context for people who were otherwise just completely emotionally and existentially wrecked by getting a terminal illness diagnosis.
Right.
Yeah.
Yes. Logotherapy goes back to Viktor Frankl.
Viktor Frankl. Thank you. Yes. Yeah.
Man, short list of books that totally changed my life as a young person was Man's Search for Meaning.
Yeah, I highly recommend reading that book. It was great to actually read that book before working on the study as a co-facilitator as well.
Yeah. So, it really should be part of all nursing, all curriculum for anybody who's going to work with anybody who's suffering, right? I think it's, I mean, this was written by a psychiatrist who survived a concentration camp. In Germany or Austria. And but I mean, really, if you had to distill it down, it's sort of like if you have a reason for living, you can survive, you can endure almost any kind of circumstance that you find yourself in.
Yep. That's right. And so what happens a lot with terminally ill end of life folks is so much is being stripped away from them before they even get to death, right?
Right.
They lose their roles that they might have in their family or their jobs. They lose their functioning. They lose their independence. They lose a lot of their identity. They lose sometimes their physical appearance. And so by falling back on meaning and purpose therapy, it's kind of this beautiful attempt to restore them to the essence of what matters most for them as they decline.
Yeah. And there's a component out there around dignity in there too, it seems like.
Yes,
Well, so that's
absolutely.
it's another thing that end of life often seems to bring about is a lot of indignity, I mean, just not being able to get to the toilet by yourself, or
Yeah,
not being able to brush your own teeth or whatever, things that we just sort of take for granted
absolutely.
when we're healthy. Yeah. And I think, a lot of nurses kind of do this kind of instinctively, right? You
Hmm. Yeah, yeah, I think that's a really good point. And so it's been a really lovely learning experience for me in this trial as a hospice nurse, because I get to see that we're already kind of geared for this type of work
Yeah.
with psychedelics, you
Yeah.
know?
Yeah.
And then, the next part of that from here on out, for me in my research, is how do we safely adapt this for people who are at the end of life, who may have further complications that exclude them right now from clinical trials, right? So that's a whole other can of worms that we're going to be opening and sorting out soon.
Right. Because for people that aren't familiar, I mean, there's a lot of reasons why people can't be in a clinical trial. Right.
Yeah.
And usually the top ones are like, you have some major medical situation going on that precludes you from, being able to be treated. And it's like, it goes back to like safety. A lot of times it's like, well, we don't want to do anything to harm you.
Yeah.
You're in the study, so we're not going to take you in if you're at a higher risk. But you're obviously taking people that are at higher medical risk, because
Hmm.
they've got it. But there's precedent for this, right? I mean, this was done at Hopkins, and this was done. Charlie
Totally.
Gross did this back in like the early 2010s at UCLA. So you guys are carrying on that tradition, but really, it sounds like really kind of focusing the therapy part a little more, perhaps. I mean, so the psilocybin is still kind of an active part, but the therapy sounds a little more refined as to what you're delivering.
Yeah, yeah, I think so. And, it's just going to take probably a number of years for us to really sort out the details. And that's part of my commitment going forward as a nurse scientist in this space is how do we actually design and implement psilocybin therapy for end of life folks where even if they're in a wheelchair or even if they have a Foley catheter,
Right.
in theory, they should be able to receive this intervention safely. It's just a matter of fine tuning our protocols and training the facilitators how to manage all of that stuff during dosing.
Right.
So,
So part of your role is really kind of as an advocate of like, how do we make this more inclusive? How do we have these folks that might not otherwise qualify for a study be able to be treated?
yeah, and widening that eligibility criteria so that it's actually realistic in real world hospice palliative care settings, right?
Right.
Because right now it's so difficult to find a whole lot of eligible participants at end of life because they fall outside of eligibility because of some complex medical thing that we haven't quite tested all the way out yet.
Yeah.
So yeah, it's going to take a number of years and many, many people, but we're pretty sure we can safely widen so that more people can receive it at the end if they choose.
Yeah. And it's not just, palliative populations either. I mean, I remember when I worked on the USONA study at UCSF a few years ago, I think we screened 500 people and we ran 10 subjects in our site,
So
so I mean, some of them just didn't qualify like from the get-go because like they didn't have depression. They're just like, I heard you giving out mushrooms at UCSF, like, well, do you have depression? Well, no. Well, then, sorry, this conversation really doesn't go any further, because yeah.
yeah,
But
there's
even but there were a lot of other reasons why people screened out, because they had various other problems. And so
Yeah.
I think when you said that the title of the study, the first word was pragmatic.
Hmm.
And I think that from my understanding of that sort of refers to what you're talking about, where it's like, okay, this is a little more like a real world situation you're going to find yourself in down the
Yep. Yeah. Yeah, absolutely. So we have a lot of work ahead, but it's well worth it, And also the other part that I think we need to keep in mind in the general medical nursing world space is there's a reason why there's such a huge interest in psychedelic therapy, particularly for end of life coping. And that's mostly because the standard medications and treatments that we have for things like depression, anxiety, existential stress related to a terminal diagnosis, it's not quite cutting it. It's not quite effective enough for many, many people, right? As a hospice nurse, I walk in, someone is beside themselves, extremely upset, distraught, has no will to do anything because of their diagnosis anymore. And yeah, we can start them on an SSRI, but that takes 4 to 6 weeks to kick in, if it kicks in at all,
right,
and side effects. And who wants that when they're already dying? Or if they're extremely upset and
right.
agitated over it, yeah, we can give them things like Haldol, lorazepam, but we're not truly helping them. And I think a lot of us nurses feel that.
Yeah, yeah. I remember giving terminally ill patients SSRIs and thinking, what the hell are we doing here? Um,
Yeah,
I mean, it feels even it, you know, back then. I mean, the critique was sort of like, well, this person might only have 2 weeks to live. Like, why are we
right.
starting a medication that's going to take a month or longer? But
Mhm.
then now, kind of appreciating the issues around SSRIs, and I know it's really fashionable to bash on SSRIs, and I think they've helped a lot of people, but they do tend to cause this kind of numbness, if nothing else. You sort of have less emotional range, and feel
Yeah.
more kind of emotionally flat, which is probably not what you want, when you're kind of making sense of the end of your life.
Yeah, yeah, absolutely. And I think for me, it all boils down to quality of life. And, you know, an end of life participant might go through psychedelic treatment with meaning and purpose therapy. And it might be kind of maybe some challenging things, some fears, some emotions come up around their diagnosis during dosing. But at the end of it, it's like if that person's quality of life is improved just because their mindset improved, then we've done our job.
Yeah.
Whereas, a lot of these standard medications, sure, they're appropriate for some people who prefer those, but they're just not improving quality of life
Yeah.
for too many people.
Yeah. And yeah, so I know you're in the middle of the study, and you can't kind of give away the ending of the story because we don't know what it is yet. Um,
Mhm.
I don't want you to like you know, offer conjecture on like what do you think is happening to your in terms of outcomes, but like what's been your experience of sitting with people? Because I know that's a lot of times when people reach out to us, they hear about open nurses, they're sort of interested in like what's it like, how do I do this work, so you're actually sitting with people, they've taken psilocybin, you're there with them all day. What's that experience like?
Well, just to be clear, that technically we don't know what they're receiving, right?
Right, yeah, thank you, yes, that's true. So they've had a something that's going to have some effect on them because they're either going to get psilocybin or ketamine, right?
Yep, yep, that's right. So it turns out at this point, um, I now know that I've sat with folks who've received both the ketamine and the psilocybin. And, sometimes it's kind of a long and boring day, especially when you're waiting for the study medication to kick in and they're nice and relaxed on the couch and it's quiet and the music's going. And There's a lot of time where you're just kind of sitting there.
Uh-huh.
Maybe a lot of people don't realize that it's an 8-hour day.
Uh-huh. I'm
And then,
smiling because I've been there. You're like
yeah,
kind of watching paint dry,
yeah, kind of sometimes. But then, when things start to move for people, I think, as a nurse at the end of life for folks, it's really not much different from being at the bedside of the dying, right? Because we're, as nurses, especially palliative and hospice care, we're so used to people's consciousness and mental states fluctuate greatly,
Yeah.
right? And anyone who has experience with patients going through delirium or just any sort of psychiatric flare up, it's really not much different from that.
Yeah.
And so, when people are moving through whatever they're moving through emotionally, spiritually, whatever, it's just like, oh, yeah, it's just as if this person was on their deathbed. And it's okay. And so, one of the benefits to being a nurse as a co facilitator in this space above ground
Mhm.
is we're not phased by much from participants, I think, right?
It's true.
So, I think one of the benefits is we can allow people a wide berth of space
Yeah.
to go through their stuff without being terribly alarmed.
Right.
Yeah.
Yeah. That totally makes sense because, one of the things what I've noticed in training people in this, and I'm curious for your thoughts on this too, is that um, there's kind of like an untraining that has to happen for
Mm.
some professionals, where they're like, oh, wow, you're hearing voices of dead people. I better get the Haldol, right?
Yeah.
Whereas like in this setting, it's like, okay, what are they saying, right?
Yep. Yeah, that's right. And of course, we have our safety measures as well, and we're keeping track of people's vitals and making
Sure.
sure people aren't going off the deep end into any unsafe like mania or
Yeah.
anything that would not be therapeutic, right?
Right.
But besides that, it's like, especially for people at end of life, they're going to go through some stuff,
Right.
you know.
Are there like pragmatic challenges that you have, like, people that have had, like a colostomy or, a urostomy or those, 'cause I'm thinking about people that have life-threatening illnesses often have, medical complications, right? From as a result of their treatment, right? Like, have you had to deal with any of that kind of stuff?
So far, I only know of the UCSF site because we're a 5-site study. But at UCSF, I'm not aware of any participants with things like colostomies or catheters. I think our eligibility criteria is quite narrow.
Okay.
I think it is being looked at to widen it a little bit.
Okay.
But, that's part of my current postdoc work is I'm actually developing a manual to be implemented in states where there are clinics that are serving psychedelic therapy to end of life folks so
Okay.
that it can be somewhat standardized and widened to allow people with colostomies or catheters or whatnot to have this experience if they choose and if they're appropriate. It's
Right.
just a matter of training the facilitators and the clinic teams, right?
Yeah.
So I honestly don't see any reason why someone with a Foley catheter, which is fairly common
Yeah.
in palliative care, especially for men, right?
Yeah.
There's really no good reason why they should not receive psychedelic therapy at all.
Yeah.
It just is going to require some like protocol adjustments and some more um, preparatory
Right.
stuff before dosing to make sure that everything's working a-okay and there's not going to be any issues during dosing day. But really, that's the kind of like where the rubber meets the road kind of pragmatic stuff that we're working on right now.
Yeah. I mean, if anything, I could see it being easier because,
Yeah.
one of the things I always worry a little bit is when, somebody's like, 2.5 hours into a psilocybin session and they're really at the peak of their experience and they're like, I gotta pee. And you're like, okay, we're gonna go out to the hallway and I'm gonna, make sure you don't fall down or get confused. So yeah. So Foley, well, that gets that out of the way. Um,
Totally.
yeah, but you have to, you're right. I mean, like not all of our colleagues are going to be comfortable dealing
Yes.
with somebody with a Foley, whereas nurses, like
Sure.
I was emptying Foleys in my second week of nursing school. Like I'm sure you were too.
Yeah.
Um, so well, that's a good segue to you mentioned your postdoc work, and so obviously your credentials there. You got your PhD in nursing. A lot of people, I hear from a lot of people who are nurses who are, the sort of recurring theme in the messages we get to open nurses are like, how can I get involved in this work? Like, I want to, maybe I want to be a researcher. Maybe I want to work in a clinic. Maybe like I want to do something in this space. And, I think a lot of us have this idea that like, oh, you get another degree in order to do the next thing, and like I've had people say to me like, should I get a PhD? I'm like, well, only if you have a very clear goal for that. Like, don't just go,
Yeah.
don't do that to yourself just for fun, like, because there's not a lot of fun in it. So, I would love to hear how you chose that path, like why you decided to get a PhD. So like, for example, like you're not a nurse practitioner, right? Like, so you're an RN with a doctorate, uh,
Mhm.
and your doctorate. I mean, tell us about that, how you made that decision, and like, what was your training? Like, what were you learning to do in graduate school, and what are you working on now with those skills?
Yeah, so I decided to go straight from my BSN, just working as an RN, straight to a PhD, mostly because I knew for my longevity in nursing, it was going to be limited if I stuck to bedside clinical care,
Totally.
just for where I was at in my career. And also, COVID happened. And I
Right.
was at the front lines in COVID working as a triage nurse, which is a whole other story. But I knew that, okay, it's time to make a pivot here, but I still want to stay within nursing.
Right.
And so I decided to go more of the research route versus the more like hands-on DNP route. And I think honestly, I was just in the right time at the right place. And UCSF was very kind and trusting, accepting me into the program. But basically, I think the only difference that I see being an NP, DNP versus an RN doing actual psychedelic research is I might not be able to serve as one of the study providers. So, what does that mean? That means like I probably cannot, well, I know I cannot administer the study medications myself. It has to be a study physician. I
Mhm.
can't do certain parts of the study assessments. It has to be done by an MD, NP, or DNP. And I don't have a DEA license.
Right.
Besides that, I'm plenty busy as it is in these psychedelic trials. So I don't feel like I'm missing out on that part.
No.
Um, and I think just being an RN with a doctorate, that really positions me to work on implementation science. And so, what
Right.
does that mean? That means actually tailoring things to work for people on the ground, because I think that's the beauty of being an RN is we're in the trenches. We have
Right.
our sleeves rolled up. And that's why I'm such an advocate for nurses to get into this space. And so I would say, anyone wanting to get into the psychedelic space um, above ground, you know, I would just look at any trials that you come across happening. You can go on to clinicaltrials.gov
Mhm.
and just poke around. You never know what institution, what organization needs an extra hand. And if you're a nurse and you have these clinical skills, and especially if you have a little bit of research or writing skills, just go fishing, put yourself out there, because there's so much interest and enthusiasm around psychedelic science and research right now. but not everyone is a nurse or a clinician, right? And also, there are programs to become a certified psychedelic facilitator or guide. And some people find those helpful and some people don't, but that's something to look into as well. So I would say just keep an open mind, and your hands-on skills as a nurse is valuable and needed.
Right. So, I'm assuming that, I think only 3% of nurses have doctorates, and probably most of those are DNPs. So, PhD in nursing is a fairly rarefied thing. Um, so for people that are thinking about doing doctoral work in nursing, could you lay out sort of what the difference is between like a DNP and a PhD route, and like what were you doing during those years? Because I remember, you and I met, I think your first year of your doctoral program, and it seems that doctoral PhD work is a lot more entrepreneurial. Like you got to go find the things that you want. You're not just going to show up and be like, they're going to hand it to you. Like you got to go find it.
Yeah, totally. So yeah, it's really like once you get to the terminal degree part of nursing, you have to make one or two decisions. You either go the PhD route or you go the DNP route. My understanding of the DNP, doctorate in nursing practice, is it's more of a clinical systems-wide training where you likely will be in clinical environments like ICU, ER, other sorts of critical care, and you're kind of overall working the clinical systems-wide route. You'll likely be in leadership of the hospital, et cetera, very hands-on. You can do research and publish as a DNP, but it's more like still in the trenches, still on the ground, operating as a DEA licensed provider, as a nurse. And then the PhD route is, I think, much more nerdy. You have to be a super nerd to go the PhD nurse route. And so that means like a ton of self-imposed alone time, really getting into the weeds and investigating all the nooks and crannies of whatever your research focus is. Um, it is a ton of going out there and networking on your own and absorbing and collecting all the bits and pieces that you do not yet have for your research focus. And then it's a lot of ambitious pursuit of funding, which is challenging these days for a lot of reasons, as we all know.
Yeah.
And so, yeah, the PhD nursing route is very much focused on like the dissemination of the findings, the dissemination of the new knowledge. And ideally, that is passed on to the DNPs and will cascade down the whole profession out there.
So when you say funding, like let's decode this a little bit, right? So like when people say, "Oh, I lost my funding," or "I'm looking for funding," like they're talking about like I need to find a place or funding that will pay for me to do this work. Like basically you're looking for your salary, right? Like and for the expenses of the study and for anybody you're paying.
Yeah.
Right?
Yeah, that's right. So funding is basically, I need to get paid to make a living. And also there's, we need to provide for the expense overhead of actually running a study.
Right.
And so basically what I've experienced so far is funding is like a patchwork quilt these days, right? It's like, for example, I'm technically NIH funded, which I'm very grateful for, and may it continue and remain intact.
And NIH stands for?
Thank you. National Institute of Health.
Okay, so that's a federal agency.
It's federal funding.
That funds healthcare research for people that are not familiar, right?
Yes. So my particular funding from the NIH is specific for postdocs.
Okay.
So, and then I get like a tiny part from the lab that I'm helping out because they're very generous and nice.
And just to do a little terminology clarification for the audience, like, so you finished your doctorate, you're Dr. Whitmore, you have your PhD, now you're doing a postdoc,
Yeah.
which now is that like, for those who aren't familiar, is that like a residency? What the heck is a postdoc?
Yeah, postdoc is basically like a junior independent researcher time where you're you're getting geared up to almost go out there on your own and be a primary investigator, the one who's leading a study trial.
Okay.
So the PhD kind of got me the research skills that I needed and to really establish myself in my chosen research field. And then
Okay.
a postdoc is we're basically doing an internship of some sorts
Okay.
in science and academia and research. And so some people, their postdocs last 1 years, 2 years. I've heard up to like 6 years, which is super intense, and I'm not planning on doing that.
Yeah.
But, you know, usually after the postdoc, you move on to much more of an independent researcher role, maybe as faculty at an institution, or maybe you move to industry for a private organization.
Okay. So you're doing additional, because usually when people finish a postdoc, if tell me if I've got this wrong, but like they often apply for a faculty position somewhere. They become a professor at a school of nursing where they're continuing to do research.
Yeah, so often it's usually you try to go for some sort of faculty position where your time is split maybe between research activities on a trial and or teaching.
Right.
Depends on what you want to do and what the options are at the time. Or some people kind of split it and they decide to go into what we call industry, which
Okay.
is not associated with like a public university like UCSF. It's like private business industry. You're on your own. You might work in the capacity of like a consultant or working for biotech.
Right.
Uh, yeah, private industry.
So like a pharmaceutical company would be an example of
Yep.
industry, right? So
Yep.
like, so if let's say, a big pharmaceutical company who's working in psychedelics wanted you to help them lead a clinical trial of psychedelics in palliative care, you'd be well suited to do that because of your research experience and your clinical experience and your postdoc.
Yeah. Yeah. I guess technically I
Okay,
would.
got
Yeah.
it. Yeah, I just think for a lot of nurses, it's kind of murky, like what happens after, you become an RN or an APRN. Like we all obviously had nursing school professors, but
Yeah.
like, nursing is weird because there's so many different routes to like the same places, and
Yeah.
nobody ever really tells you how that works.
Yeah, it's true, it's true, and I've been basically freestyling the whole time, like, since grad school.
Yeah.
You you just figure it out one step at a time, but I do have to say, what I learned was find the helpful advisors.
Okay.
Find people who are doing what you think you might like to do or at least check out.
Right.
So, my advisors, and you were part of my advisory committee during my quals, Andrew.
Yeah.
They've all been super helpful and enlightening to kind of shine the way forward for me. And, we just kind of accept that we're making it up as we go. That might not work for some people, that level of instability or not quite having a carved path. But if you're into psychedelics and if you want to get serious about this work,
Yeah.
I think it's one of those things where you have to accept that that's part of the beauty of it is we are freestyling this. We are creating this together as we go. So that could also be a great leverage for us, right? So connect, network, hang on to the people whose work you admire
Right.
and who you want to kind of investigate further with and see where you end up. But I would say don't squander yourself. Don't sell yourself short thinking, "Oh, I'm just a nurse. I don't think I can get in this," because that's not true. We're actually very needed in the
I love that.
space.
I love that. And you're too modest to your own horn, but you're a good example of that because you know, I mean, I remember when I don't think I knew you before you started grad school, and I was teaching at UCSF in a different program. Like, so I taught the Psych NP program, which is, you know, a master's program at the time, and it was different than what you were in. But like, you know, you just shot me an email and you're like, hey, I see you're doing this kind of work. Can we talk? And like, we had coffee and like, you know, like, so that sort of scrappy entrepreneurial
Yeah.
spirit of like, hey, there's somebody doing the thing that I'm interested in. I'm going to go talk to them. And like, you know, we were all told in college to like network, but nobody ever tells you what exactly that means.
Yeah.
like what do I do? You know, like, well, you sit down, you have coffee, and you say, what are you doing? Like, you know, what's that like? And do you know
Yeah.
anybody I should talk to? And, you know, I gave you some names of people that, you know, sometimes it's a dead end, sometimes it turns into something really great. So like your advisor, for example, Heather, she's not a psychedelics person per se, right?
No, not necessarily. She's a psychiatric nurse practitioner, and she also specializes in geriatric psych, I believe. No, but she was so kind and gracious at the very, very beginning. You know, I needed an advisor in the School of Nursing to take me on for my PhD.
Right.
And she's like, we'll figure it out. And we have.
Nice. Yeah.
So I would say, like, you know, if psychedelics teach us anything, it's that we have to have an open mind of curiosity. And so I wouldn't exclude any options, you know, like I would not have guessed that my advisor, Heather, would be open to it, but I just went for it.
That's excellent.
And she opened up the doors to meeting my current postdoc advisor, Dr. Brian Anderson, and some other wonderful folks, and Dr. Maria Mangini and yourself. And so one thing can lead to another, right?
Totally. Totally. And that's why I always tell people when you do an informational interview, you know, which is different than like a job interview because you're not necessarily wanting something from them,
Yeah.
you know, and like, so if that person says like, hey, do you know so and so, and if you don't know them, like, be like, would you be willing to introduce me? You know, I
Yeah.
mean, that's like the mechanics of like one thing leads to another, right? You know.
Yeah, exactly. And I would say like the time is now. If
Mhm.
you're seriously interested in getting into the space and you're a nurse, just start putting yourself out there and connecting with folks, you know?
I love that. Hey, there's a question here. We have a few minutes for questions at the end here, but so if people have questions, pop them into the chat. Michael wants to know, was your PhD, was your dissertation actually in psychedelics?
It was. So my dissertation was a mixed methods analysis looking at psychedelic therapy in serious illness for death acceptance.
Okay, break
And
that down first. Mixed methods means,
mixed methods means you're using statistical analysis as well as more of the qualitative interviewing or transcripts of interviews of study participants. So it's combining both at the same time and looking at those results side by side.
so there's like numbers and statistics and stories.
Yep, exactly. So there's like a human element with the
Yeah.
interviewing qualitative part, and then there's like hardcore numbers part
Oh,
because we're
okay.
the NIH.
And what was the question you were trying to explore?
I was exploring if psychedelic therapy in folks with serious illness can help with death acceptance.
Okay.
And so I was able to use transcripts and data sets that had already been completed before I got onto the scene. And I was able to analyze them because they hadn't yet been analyzed for that yet. And lo and behold, it appears that psychedelics may help promote death acceptance in serious illness.
So this is so you know this stuff, but let's decode it for our audience. So like, so you were taking an existing set of data, like
Yep.
they transcribed these interviews that people had done with that had, you know, life-threatening illness and were getting psychedelic treatment, and you went back through them and looked for different new stuff.
Yeah, that's right. That's right. So my angle of questioning was different from what had already been analyzed on those data sets or those interview transcripts.
Okay.
So, and that's another example of kind of getting creative as a nurse pursuing this work is, oh, I only have 3 years of guaranteed funding in my fellowship. I don't want to have to go out and hustle and get a 4th year in this economy.
Right.
How can I do this quickly?
Uh-huh.
And that was one of the ways that I decided to do it, is using existing data sets, asking questions that hadn't yet been explored. So it
So
worked out.
that saved you time because you didn't have to go get additional funding to go out and ask these questions to a whole new
Yes.
set of people, right? You could like say, hey, we already have this data from this other study. Let's go
Mhm.
through it again and like see if we can comb out for this other stuff, these other questions that we have. Is that accurate?
Yeah, and it just worked out because, the topic of death acceptance is so critical in end of life care, as we know, right?
Right.
So it just was really good timing and really good circumstances for me.
Excellent. Okay, that's really cool. So we're almost at the end here, and we always have this sort of traditional ending to these interviews, which I think is kind of fun, which is, if you were going to go back and ask and give your younger self some advice, is there a thing you would tell them? And that could be, that could be yesterday's younger self, or that could be 4 years ago, Hannah, when you were starting your doctorate, or it could be, much further back in the past. So what would you say?
Hmm. I would say don't get discouraged if you don't gain traction right away. So there's going to be little failures here and there. There's going to be a steep learning curve. There's going to be some awkwardness for a lot of different reasons, but it's all part of it. Just expect it. And if you persist, you'll get there. And
Yeah.
and you're very much needed. So like I didn't get into the UCSF PhD program the first try, and I was like so upset over it. And then I rewrote my entire application. I got in the second time, and it was just much better circumstances, much better timing. Heather, my advisor, was available for me. So don't get discouraged by the setbacks. They will happen.
Yeah.
It doesn't mean as much as you think it does.
Tenacity is a rewarded trait.
Mm.
Yeah. No, and you've had that through this. I mean, I've kind of watched your trajectory from a distance, watching you go through this, and you had some moments where it was like, the thing you thought you were going to do didn't pan out, so you had to pivot. Uh,
Totally. Yeah.
but I've also seen how like you've really, made a lot of connections in the space, and that people, you've been able to help out people and they've been able to help you out in return. And there's a lot of that kind of reciprocity that happens in
Yeah.
this work. I mean, it goes back to when we were floor nurses, right? And it's like, hey, can you cover my lunch while I go, I need to run out to my car. Can you watch my patients?
Yeah.
That's reciprocity. And you're like, yeah, and you'll do a favor for them. Like it's
Totally.
just a different version of that, right?
Yeah. Absolutely.
Yeah. Well, this has been really cool. I think a lot of times, when people think about getting a doctorate in nursing, they're kind of intimidated by it. It's like, what does that mean? And like, especially a PhD, I think the DNP is becoming more kind of the norm for like advanced practice, uh, APRN kind of work. But the PhD is still this very kind of fairly uncommon thing.
Yeah.
Outside of nursing school, like where a bunch of people have them, but like, and most people don't work with PhD nurses. So, your down to earthness is a breath of fresh air. And,
Mm.
and I hope it inspires people, so it sounds like if you really have a question that you want to answer through research, and you want to learn how to do that research and you want to start doing that research,
Mhm.
maybe a PhD makes sense.
And if you're okay with writing a lot,
You got to write a lot.
you gotta
Yeah.
write a lot.
And,
Yep.
and you can't just do chart note abbreviations. You got to actually write full sentences.
Full-on sentences, you guys.
None of the LCTA stuff anymore. Or
Nope.
what is it? WNL. We never looked. That's
That's
what I
right.
was. That's what I was told WNL stood for. It's like not within normal limits. It's like we never looked. Um, but when you get back to the nurse's station, you realize you didn't actually listen for lung sounds. All right. Well, Hannah, thank you so much for taking the time. We had a little bit of a technical glitch. So I think this went out on our Facebook stream, but we'll figure out how to get this onto the YouTube channel, hopefully, when this is all done. But thanks to the audience if you had some hiccups in getting on with us. But I did see that there were a bunch of people that watched us in the live stream, and we'll very much hope to get this out onto the YouTube so people can watch it later. So Hannah, thank you so much. Really appreciate it. It's nice to see you as always.
Okay, thank you, Andrew.
Thanks,
Bye.
Hannah. Bye.